I am Holly Edlin-Bess, and I will be presenting on behalf of Ayeli Ba, Sally Ibick, and myself in regards to the changes since 2016 to the Patient Protection and Affordable Care Act put into law in 2010. Included in the passage of the ACA was a penalty for not complying with the individual mandate, which required health coverage for every individual. The penalty was $695 per adult, $347.50 per child, up to a maximum of $2,085, or 2.5% of income for each family, whichever was greater. As of January 1st, 2019, the penalty has been repealed. Some states chose to create their own individual mandate penalty after the elimination of the federal one. Throughout the last two administrations, funding for the ACA has wavered drastically. President Trump's first administration oversaw a reduction from $98 million to $10 million annually to the ACA Navigator program, which helps individuals with coverage assistance. During President Biden's administration, funding was increased to $98 million annually and received a grant of $100 million in 2024. As of 2025, President Trump has reduced their annual funding to $10 million once again. Skinny health insurance plans cover preventative and wellness services and fulfill the mandate requirement of the ACA. When purchasing insurance, individuals usually weigh their risk against the cost. Skinny plans are selected by generally healthy individuals with low risk. The insured pays a lower premium and is offered limited coverage. During the COVID-19 pandemic, many businesses closed and many individuals found themselves without the employer coverage they had previously had. To combat this challenge, the ACA offered a special window to purchase ACA plans. An increased need in telehealth services also presented. These services were not previously covered. Constant legal challenges have plagued the ACA. The constitutionality of the act has been questioned. Coverage of contraceptives was also addressed. Fluctuations in federal subsidies impact premiums. President Trump's administration reduced these subsidies, which resulted in higher premiums. During President Biden's administration, these enhanced subsidies were reinstated and reduced premiums of ACA plans by 44%. When considering the effect on quality, the uninsured receive fewer preventative services, poorer health outcomes, delayed diagnostics, and more difficult chronic disease management results. Higher rate of coverage correlates with better outcomes. An estimated 2.3 to 13 million individuals have dropped coverage since the individual mandate repeal, limiting access. Fluctuations with ACA Navigator funding have not impacted access. However, subsidies do. Those with skinny plans have a more limited access to healthcare as their coverage is minimal. Demand for marketplace plans does not fluctuate with ACA Navigator funding amounts. The reduction in refunding to the ACA Navigator program has not impacted demand. In 2019, 205,000 consumers utilized the program when funding was at its lowest. As of 2024, when funding was at its highest, only 86,000 consumers used the program. ACA Navigator funding reduction will result in lower premiums for consumers by lowering the user fees required by insurers. Conversely, with more healthy individuals opting for skinny plans with reduced cost, premiums increase. Out-of-pocket copays are increased as well. Hospitals are also left covering many costs the uninsured who receive treatment but are unable to pay. Increased subsidies result in lower premiums, and decreased subsidies result in higher premiums. Healthcare exchanges can be defined as platforms where individuals view the various healthcare plans available to them and purchase their choice. They can weigh coverage benefits and cost and select what suits their needs best. Exchanges increase market competition and affordability. They are a convenient way for patients to compare all of their options. The most frequented federal exchange is healthcare.gov. It offers diversified plans, and cost and availability depend on risk factors, location, age, and income. The Federal Healthcare Exchange was established by the Affordable Care Act in 2010. It provides a centralized online platform, healthcare.gov, for people to shop for and enroll in ACA-compliant healthcare insurance plans, particularly in states that did not create their own state-based exchanges. This exchange also offers financial assistance. including premium tax credits and cost sharing reductions, to help lower income individuals and families afford coverage. This is a critical step towards reducing disparities in access to care. Enrollment is typically available during the open enrollment period, but individuals who experience certain life events, such as losing coverage, marriage, or childbirth, qualify for a special enrollment period. Importantly, the exchange helps support the goals of the Triple Aim: improving the patient experience, improving the health of populations, and reducing the per capita cost of healthcare. The federal exchange remains a key component in improving equity and access in the American healthcare system. State healthcare exchanges are health insurance marketplaces run by individual states, authorized under the ACA. These exchanges allow states to manage their own online platforms where residents can shop for ACA compliant insurance plans, apply for a financial assistance, and enroll in coverage. While some states use the federal exchange at healthcare.gov, others have chosen to build and operate their own systems. Examples include Maryland Health Connection, Covered California, and New York State of Health. These state exchanges often provide greater flexibility in areas like enrollment periods, outreach efforts, and plan customization, which can tailor programs to their unique populations. State exchanges still follow ACA guidelines, but may be more responsive to local healthcare needs, leading to more effective coverage expansions and better health equity. Their efforts also align with the Triple Aim framework, improving the quality of care, enhancing population health, and controlling cost. By providing accessible coverage options with income based subsidies, state exchanges help address insurance gaps, especially for underserved communities. In doing so, they play a vital role in strengthening the overall healthcare delivery system. Hybrid healthcare exchanges are a middle ground model between state run and federally run health insurance exchanges. In this model, the state oversees plan management and consumer assistance, but uses the federal healthcare.gov platform for enrollment and technical operations. Hybrid exchanges allow states to maintain some autonomy and oversight, such as setting their own outreach strategies or insurance regulations without having to build and maintain a full technology platform. This model is especially helpful for states that want more control and flexibility, but lack the resources or infrastructure to fully run their own exchange. These exchanges still operate under the framework of the ACA, offering compliant health plans and income-based subsidies to reduce costs for consumers. By bridging the gap between state and federal models, hybrid exchanges also support the Triple Aim goals of improving population health, enhancing the care experience, and reducing per capita healthcare costs. Examples of hybrid exchange states include Virginia, Maine, and New Mexico, which transition toward greater control while still leveraging federal systems. The ACA made significant reforms to the Medicaid program, aiming to expand eligibility to adults earning up to 138% of the federal poverty level, including low income adults without dependent children who were previously excluded. Medicaid was positioned as a core mechanism to reduce the uninsured rate and increase equitable access to care. However, in 2012, the U.S. Supreme Court ruled that the states could opt out of this expansion. As a result, Medicaid expansion became optional, and as 2024, 10 states still have not expanded Medicaid, leaving millions in a coverage gap. Despite the inconsistency, research shows that states which did expand Medicaid saw substantial improvements in coverage, access to preventative care, and even reduced mortality rates. These outcomes support the Triple Aim framework, improving the patient experience, enhancing population health, and reducing costs. The expansion also aligns with the ethical goals of reducing health disparities. According to Smith, Brown, and Wilson, increase in access for vulnerable populations is essential to addressing longstanding inequities in the U.S. healthcare system. Medicaid expansion is part of how the ACA attempted to bring the U.S. more in line with global standards. As discussed by the Commonwealth Fund and Schoen, The U.S. spends more but performs worse in access and outcomes compared to many other high income nations. Medicaid expansion through the ACA represents a pivotal effort to improve healthcare equity, efficiency, and affordability, though its success varies depending on state participation. Premium trends under the ACA have fluctuated, particularly since 2016. The elimination of the individual mandate penalty, the end of federal cost sharing reduction payments, and other regulatory changes contributed to initial premium increases, especially in 2018. However, these increases stabilized in later years, and enhanced subsidies provided under the American Rescue Plan significantly reduced net premiums for consumers. Premium affordability remains a concern, especially in the states that did not expand Medicaid or have limited insurer participation in their exchanges. One of the ACA's most praised elements is its emphasis on preventative care. The law mandated that most insurance plans cover preventative services like cancer screenings, vaccinations, and wellness visits without cost sharing. This approach aligns with the Triple Aim framework, improving population health, enhancing care experiences, and reducing per capita cost. As a result, preventative care utilization increased, especially among previously uninsured groups, helping to detect health issues early and reduce long-term care treatment costs. The ACA has ensured coverage regardless of pre-existing conditions, elimination of annual and lifetime limitations, and coverage for prenatal care and free preventative care. At the end of 2016, when Obama's presidency was ending, over 12 million individuals were covered with an ACA marketplace plan. During Trump's last year of his first term, this number had dipped by 9% to over 11 million individuals with an ACA marketplace plan. In 2024, Biden's last year in office, the number of individuals covered by ACA marketplace plans soared to over 21 million individuals. Trump had campaigned in 2016 on dismantling the ACA. His administration and supporters championed a more market-driven approach. Repeal efforts fell short and rifts within the Republican Party were created. While the individual mandate penalty was eliminated, other aspects were left unchanged. Skinny pants were being included was a minute victory. The American Rescue Plan and the subsidies included in it lowered premiums. The current debate is over the continuation of those subsidies. For some individuals, the elimination of the individual mandate penalty and allowance of skinny healthcare plans can be seen as a negative. Fewer healthy people participating raises cost. Biden's options lacked a public plan. Several states have not opted into Medicaid expansion, limiting access. For other individuals, the elimination of the individual mandate penalty and allowance of skinny healthcare plans was a positive. They viewed their health risk as low and did not see expensive and extensive coverage as necessary. HSAs under the Trump administration offered tax advantages. Many individuals experienced lower premiums under Biden's administration, and others experienced lower premiums under Trump's administration. Whether you view these changes to the ACA as good or bad just depends on your situation.